this shows just the use of the Gore GCA device in a smaller child. So this kid's got a typical secundum ASD in the typical position with the deficient anterior rim. On echocardiogram transthoracic, you can see that there's right heart dilation, and the defect measures around 12 millimeters. In this patient who's 16 kilograms, in our institution, that's big enough to place a 3D transesophageal probe. Now, the IFU, and for most people, the comfort in positioning or in sizing a device without balloon sizing is important to consider. And certainly, particularly starting off with the Gore cardioform ASD occluder, I would recommend balloon sizing. However, in my practice, I use 3D transesophageal echo a lot for sizing, and I think that's why in this case I didn't balloon size. So this patient, as we'll see, has got a deficient aortic area, and therefore one has to decide whether or not to make sure the device is large enough to splay across the aortic root, and therefore whether or not, if you have a borderline size decision about the device, whether or not you use it size up or the size down, depending on the range. So just going through the patient's transthoracic echocardiogram, you can see here that there's a right heart dilation, the right atrium and right ventricle look large, and you can see there's on a 4-chamber view on the right here, you can see at least a moderate sized atrial septal defect. And then in the bottom left, you can see that in this short axis view, the aortic rim looks at least deficient, and in some parts of that plane, the aortic rim looks completely absent. So then if we move on to transesophageal echocardiogram, during the case, you can see here that there is a deficient aortic rim. So the aorta is just a nub, the aortic rim is just a nubbin down here, and then there's a 1 to 1.5 centimeter defect here. So from my point of view, the decision now needs to be made whether to go for I have to say, in a 12 millimeter defect that hasn't been balloon sized, I think it's important to really consider whether or not you go straight to a 32 millimeter device or even up to a 37. The balloon sizing would very likely in this case have increased the size of this defect into the middle of the range of the 32 millimeter device. Now, in this patient's case, because the aortic rim was completely absent, I was quite comfortable in going up to use a 37 millimeter device because I think that would have allowed adequate splay across the aorta to improve the security of this defect. I don't know whether it's fair to say that a 32 millimeter device would not have worked, and in fact that is what the IFU would have recommended. But I tend to, in the case where there's a deficiency of a rim or some other feature that may decrease my confidence in device stability, then I will size up. And the 37 millimeter device certainly is very commonly used and successfully used in lots of smaller children. I think as these videos play, it's important just to recognize the importance and the change that happens when the device is locked. So the fluoroscopy in this device during locking, you can really see as the covering of the wire pigtail portion is pulled back, that the wire changes from a straight wire inside the catheter complex to a curled pigtail shaped wire which locks the device together. And I think this is important to understand from the point of view of the mechanism of the device before using it. I think it would be wrong to start off in clinical practice with this device before fully understanding the mechanism, particularly by which the device locks. This is a really key step in every deployment. You can see here again, just on this view from the side, that the pigtail shape has been achieved in the locking loop, and the rest of the catheter is just waiting to be freed up by taking away the securing suture. So you can see in here, after the device has been locked, it sits nicely splaying across the aorta as we hoped for in this patient who's smaller but who's got an absent aortic rim. So the 37 millimeter device, making sure the device isn't sitting just on the aorta with a potential risk of being unstable or embolizing. So I certainly prefer using a slightly bigger device in these cases. Again, you can see here the disc nicely splaying, and this little color flash that we often see is just really interference with the edge of the device with the Doppler signal. And then down here, this is very important. And I think in a lot of children and adults with this device, but particularly in children, immediately after deployment and locking, the device has not fully, the nitinol has not fully come together and conformed. And therefore, at the SVC area, we do often see turbulence as the SVC enters the right atrium. Now, in my experience, that's a very temporary phenomenon. And by the time a transthoracic echo is performed the next day, and indeed in follow-up clinic, this turbulence has decreased and the SVC flow normalizes further and further. And that's just as the right disc comes towards the septum and conforms towards the septum. So this impression of SVC stenosis, which is really not SVC stenosis at all, or SVC obstruction by the device, is just the nature of the nitinol device not fully conforming on immediate deployment. And after, in my experience, less than 24 hours, this is pulled together onto the septum and this turbulence is taken away. And then again, in this case, we were lucky to be able to place a 3D probe. So after the device has been locked, you can see already the device is starting to flatten out against the septum. So this is the left atrial portion of the device, the left atrial disc and the right atrial disc over here. And you can see that these are very nicely pulled onto the septum. And then just from an aesthetic point of view, you can see en face, looking at the device in 3D, you can make out the sort of wire structure of the device as you go around the clock face. So from this case, I think in this patient with the 3D TE measurements was 13 millimeter measurements roughly, a PR info which is slightly prolonged, which does always make one think about a stiff device against the AV node, and I think that's an important reason for using soft devices. You can see that our intensity dropped away. The fact the septal length measured 34 millimeters, I really find that a very difficult measurement to take into huge consideration, as long as you think that the left atrium and the atrial septum are large enough to accommodate the device. So in this patient, we did use a device that was outside the IFU, and I think if we'd have balloon sized, it may have brought us up to that sort of size anyway. The splay around the aorta looked really comfortable in this case, not putting pressure on any of the components of the cardiac structure. And I think, again, it's important to note, as we will in other cases that we look at, the significant positional alteration or rotation or pivot of the device that occurs when the device is locked. Turbulence coming around the device from the SVC is very common in small children particularly, but very common after deployment of these devices. And from what I've seen, it invariably resolves on echo follow-up.